Well, good afternoon, and thank you for giving me the opportunity to discuss testosterone therapy, the past, the present, and the future. And these are my disclosures. I want to start with a little bit of history. For thousands and thousands of years, there's been a quest to find this cure for impotence. They talk about the ingestion of testicular tissue. The ancient Indians described it in the manuscripts. The ancient Egyptians also described the ingestion of testicular tissue to treat impotence. It wasn't until 1889 when Brown Sequard self-administered testosterone extracts and reported the process of reversing his aging. Since that time, there's been exponential growth in research. It really wasn't until 1935 when Buddha's aunt Rusika actually synthesized testosterone. So this drug has been around for a long, long time. In 1939, they got the Nobel Prize for synthesizing new testosterone. But one really important thing happened in 1939. In 1939, testosterone was actually used in women for female sexual dysfunction. And so, what's surprising is that today, even today, 90 years later, 85 years later, we still do not have an FDA-approved testosterone product for women in the United States. So let's talk about the past. There's two things I want to talk about the past. It gives me great joy to say that the concerns for prostate cancer and BPH, concerns for cardiovascular disease, are a thing of the past. Let me explain. So we've heard about the TRAVERSE trial, the randomized, double-blinded, placebo-controlled trial, 5,246 patients. We had to have cardiovascular risk factors for cardiovascular disease. And summary is no increased risk in MI, CV death, or non-fatal stroke, no increased risk in prostate cancer, no increased risk of BPH or LUTS. If you take a closer look at the history of prostate cancer and BPH and testosterone, there are other factors that make us feel more comfortable in using testosterone and not being concerned about these BPH and prostate cancer. 1980 to 2010, numerous case series in men after radical prostatectomy and XRST receiving testosterone therapy showing a no increased risk. 2011, we started seeing studies in active surveillance with testosterone, no increased risk. 2015 was a big year of bipolar androgen therapy to use large doses of testosterone to treat metastatic prostate cancer. Numerous studies in 2016 and review articles showing that testosterone doesn't worsen LUTS, but potentially improves BPH and LUTS. 2018, we got the AUA guidelines. Clinicians should be informed patients of the absence of evidence linking testosterone therapy to the development of prostate cancer. And finally, as I mentioned, the TRAVERSE trial with no increased risk in prostate cancer or BPH. How about the history of cardiovascular disease? 1940 to 2010, over 200 articles demonstrating that testosterone is not only beneficial for cardiovascular health, but does not worsen cardiovascular health. In 2010 to 2014, 4 studies suggesting cardiovascular risk. 2015 to 2022, numerous studies once again demonstrating the beneficial effects of testosterone on cardiac health, and then again in 2023, the TRAVERSE trial. What about the present? I think the hottest thing in the present is oral testosterone undecanoate formulations. Why do I think that? One, they're extremely effective, but you got to look at the history. Oral testosterone was invented in 1935, and the problem was it was methylated, so it caused hepatotoxicity. So oral testosterone undecanoate bypasses the liver and goes into the lymphatic system and does not cause hepatotoxicity. The problem is, in 1970 when it came out, it was available all throughout the world except the United States. Right, so the United States did not get oral testosterone until 2019, which is Detenzo. 2022, we got Chilando, we got Kysotrex. What's really nice about the orals are the safety profiles. They have the lowest rate of erythrocytosis, roughly 5%, low rate of hypertension, 7%, no hepatotoxicity, and there's emerging data to suggest potential minimal suppression of the HPG axis. What about the future? This is what I'm most excited about, because there are 6 things in the future that I think are more likely to happen, and one would be FDA label changes, guideline updates, indications for testosterone therapy to change, personalized medicine, testosterone therapy and fertility, and testosterone therapy for women. So let's go through these. This is the label. This is what it says in 2015. And it says, to date, epidemiologic studies and randomized controlled trials have been inconclusive to determine the risk of major adverse cardiovascular events. The FDA put this in 2015 and mandated the TRAVERSE trial. We did the TRAVERSE trial. It showed it did not cause a heart attack, so this has got to go. Right, it's time to go. The second things in the FDA package insert are patients with BPH treated with androgens are at increased risk of worsening of signs and symptoms of BPH. That is not true. Second bullet, patients treated with androgens may be at increased risk for prostate cancer. That is not true. This also has to go. What about guidelines? There's numerous guidelines out there talking about testosterone cardiovascular disease, testosterone prostate cancer, and many of these are outdated. These need to be updated. If you look at the 2018 AUA guidelines, prior to initiating testosterone treatment, clinicians should counsel patients that at this time, it cannot be stated definitively whether testosterone therapy increases or decreases the risk of cardiovascular events, a moderate recommendation. Again, this was made before the TRAVERSE trial. Now the TRAVERSE trial is out. This has got to go. Okay, now let's talk about indication for therapy. So if you look at the label, you can look at any label you want. It talks about the indication for use: primary hypogonadism and secondary hypogonadism. And they talk about testicular tumors, and they talk about pituitary tumors. Nowhere do I see the word erectile dysfunction. Nowhere do I see the word low libido. But the reality is that that's what we use this medication for. And there's a word in there called idiopathic. And so if someone doesn't have erectile dysfunction or low libido, I say they have idiopathic hypogonadism, and I still can treat them. Well, in 2015, they took out the word idiopathic. And so now a patient has to have a true medical condition in order for them to be considered on-label. 85% of the patients we treat are off-label. But this makes no sense. It doesn't matter if you have a pituitary tumor or you don't have a pituitary tumor. You will suffer the same and you will benefit the same from testosterone replacement therapy. So again, the indication for testosterone therapy has got to go. Now, what's exciting is the future of indications for testosterone therapy. Forget everything you learned about low libido and erectile dysfunction and muscle mass. Let's talk about some real indications for testosterone therapy, right? So the real indications in the future you're going to see are, if I give someone testosterone, can I improve cardiovascular disease? Can I improve depression? Can I improve osteoporosis? Can I improve diabetes, obesity, and prostate cancer? I think the answer to all 6 are yes, right? But that's where the future is going. I'm going to give you an example of just a few. One is the T4DM trial. 1,000 patients randomized to Nebido or placebo, looking at diabetes, right? And so 80% of these patients had prediabetes, 20% had new diagnosed diabetes. Men with prediabetes, if they were started on testosterone, only 50% of them were going to progress to diabetes. If they did not start testosterone, 7.5%. If they did not start on testosterone, 15%. So it was a 50% reduction in progressing onto diabetes. And if you look at the men who had diabetes and they were started on testosterone supplementation, you see a greater reduction from diabetes to prediabetes if you were on testosterone therapy by 13%. So maybe in the future, using testosterone as a treatment for diabetes or prediabetes makes a lot of sense. One of my favorite examples is prostate cancer. If you've not seen this trial, you've got to read the trial. This is the Transformer trial. Randomized trial comparing bipolar androgen therapy, high doses of testosterone, versus enzalutamide, which is standard of care, in men who failed abiraterone. So they have castrate-resistant metastatic prostate cancer. Very simple. They said, look, these men have metastatic prostate cancer, standard of care is enzalutamide. Let's just randomize them to high doses of testosterone or enzalutamide, and let's see what happens, right? So they follow these men for over several years, and the take-home message is this: there's no difference if I give them enzalutamide, which is standard of care, or high doses of testosterone for overall survival. And in this trial, you were allowed to cross over from one arm to the other. So if you started with high doses of testosterone, guess what? You had greater survival than enzalutamide alone, which is standard of care. Remember that enzalutamide costs $7,500 a month, testosterone costs $30 a month. Big study, very important about bipolar androgen therapy and a different way we think about testosterone and prostate cancer. Now, the next one is personalized medicine. It makes no sense to me that every man in the room has to feel bad below 300, and we all have to be a good above 300. That is nonsense. All of us have our own set point. And the best trial I've seen by Handelman's group is when men all got Testapel. They got testosterone pellets. And the second the man started having symptoms, they checked their blood. And what they found was that each man had a reproducible number where they had hypogonadal symptoms, and every single man had his own number. So this man, every time he hit 450, he knew he was low. Every time this man hit 250, he knew he was low. 350, all of us have our own set point. We all have our own numbers, and it's reproducible. So in the future, maybe using CAG repeats, other modalities to use personalized medicine, but the concept of one number fits all doesn't work. Okay, testosterone for women. Still no FDA-approved testosterone for women. Remember, women also suffer from low testosterone just like men. Women also benefit from testosterone just like men. And we still don't have a single FDA-approved testosterone product for women. Minimal research in testosterone for women, which needs to change. The indications for testosterone for women are simply right now low libido. Testosterone has far greater benefits than just low libido. How about arousal, orgasmic disorder, depression, bone? Many, many areas of research that we have to look into. And the last one is testosterone for fertility, and the use of exogenous testosterone to minimally suppress the HPG axis. There's data to suggest that intranasal testosterone may not shut you down, and now there's data to suggest that oral testosterone may not shut down the axis. In the future, we may stop looking at the pituitary, stop looking at the testicles, focus on the hypothalamus, right? Using agents to secrete GnRH, which will then increase FSH and the LH from the pituitary, may be another smart way to approach this problem. Looking at stem cells may be another approach, looking at Leydig stem cells injected to the testicular tissue so that the man will start making his own testosterone as opposed to giving him exogenous testosterone. And finally, from our institution, looking at shockwave therapy on the testicle to induce more testosterone production from Leydig cells. So in conclusion, the past, we have no longer concern for prostate cancer, BPH, or cardiovascular disease. In the present, look at the oral testosterones. They're really going to be a game changer, I think. And in the future, look for FDA label changes, guideline updates, changing the indications for testosterone therapy, personalized medicine, testosterone therapy for women, and testosterone for fertility. Thank you for your attention.